All right. Hello, friends. Thank you for taking the time to come listen to our capstone presentations. Becca and I have worked really hard on these, and I think we both have some great and valuable information for you guys. For those of you guys who don't know, my name's Julie, and I'm a current physical therapy resident in women's health here at GSPP. And the project I've been working on is a literature review on optimizing physical birthing outcomes through physical therapy interventions. And this stemmed mostly out of my own anxiety about the topic, but I think it's a population that's really underserved, especially in the United States, and it's something I'm really passionate about. So I'll do my best to address those of you guys tuning in to the virtual world and those of you guys that are here in person. But if for whatever reason you can't hear me, just let me know. And then I have worked pretty hard to condense this into 45 minutes. So there are some topics that I'll go briefly through, but like Denise said, we'll have about 15 minutes at the end for questions if you guys have them. And then I'll put my contact information up if you need. All right. Okay. So our objectives today are to discuss the incidence of birth and delivery related complications, reviewing pelvic floor anatomy, physiology, and biomechanics during vaginal delivery, discussing current literature on prenatal physical therapy interventions, discussing intrapartum acute and 6-week postpartum PT interventions, and then recommending marketing strategies for all of the above. Okay, so so in 2018, there were 3.8 million births in the United States. Among, am I sharing my screen? Can you guys see the presentation? We can see it. You guys can, but.
Looks like they cannot see it for a comment here.
Okay, yeah. Let's get a second to get my screen up. Okay.
Actually, I cannot see the
Let's see.
the conversation.
And share screen. Share content. Here. Can you guys see it now?
I can see it. Hopefully others can share the comment.
Cool. All right. I think we should be good to go.
It's taken care of.
Okay, perfect. Great. Thank you. So in 2018, there were 3.8 million births in the United States. Among these patients, 77.5% began prenatal care in the first trimester of pregnancy. The incidence of perineal tearing during labor is estimated to be between 1.3 and 5.8%, though an increased risk was found with higher birth rate, instrument deliveries, and not having had a previous vaginal delivery. The use of episiotomy was not associated with an increased risk for perineal tearing, and then many of the patients developed subsequent anal incontinence, urinary incontinence, and sexual dysfunction, even if they had an adequate primary sphincter repair. Okay. And then these next few slides are going to be very much a review for my pelvic PTs, but I wanted to go over the pelvic floor anatomy biomechanics for those of you guys who might not be directly treating the pelvic floor, and also make a very important and often misunderstood point. So the pelvic floor is a sling of muscles that supports our internal organs. It surrounds our sphincters. It helps regulate intra-abdominal pressure. And the pelvic floor muscle fibers, like all voluntary muscles, become more elastic with careful repeated contraction and relaxation. So during delivery, the pelvic floor should relax and allow the vaginal canal to open. And so while the pelvic floor will heal and recover more easily from birth if it is strong, the ability to release these muscles is just as important, especially during the pushing phase of delivery. And then a tense pelvic floor can actually slow down delivery, which puts our patients at risk for delivery-related complications. Okay. And then a review of the degrees of perineal tears. So a first-degree tear involves the vaginal mucosa and perineal skin, but no underlying tissue is involved. In a second degree, the underlying subcutaneous tissue and perineal muscles are torn. And a third degree, the anal sphincter musculature is involved. So this can be broken down further based off of the total amount of the anal sphincter that is involved. And then in a fourth degree, the tear extends all the way through the rectal mucosa and into the sphincter. Okay. And then phases of labor. So in pre-labor, the patient will likely experience Braxton Hicks or false contractions. So this can occur as early as the second trimester. The frequency and duration of these is variable. It's affected by position and changes based off of activity of the patient. There aren't any abrupt cervical changes during this phase, but slow effacement or thinning of the cervix is possible, especially in women who have had multiple pregnancies. And then during this phase, the fetal head should also begin to engage in the pelvis. Phase 1 is considered the onset of true labor and ends when the cervix has completely dilated. So during the latent phase, the cervix dilates to 6 centimeters. The fetal position may or may not change, and contractions are regular or irregular, and they vary in frequency and duration. They're typically mild to moderate, so the patient may be distracted during the latent phase. However, during the active phase, the cervix dilates from 6 centimeters to 10 centimeters, and the fetal head drops. This typically lasts between 3 to 5 hours, and the contractions are less than 5 minutes apart. And then during the end of the active phase, a transition occurs while the cervix is dilating those last few centimeters, so 8 to 10 centimeters, and the dilation is more rapid, the contractions are closer together, and they last a little bit longer. And then phase 2 is defined as the period between the complete cervical dilation and the actual delivery of the baby. The average time for this phase varies based off of number of previous deliveries and use of epidurals, but it's generally between 20 minutes and 3 hours. The second stage of labor has 2 phases, the passive descent of the fetus through the pelvis, and then the active phase of pushing, which we're most familiar with. And then contractions intensify and the fetal head rotates and molds further into the pelvis. During phase 3, which is the period between the delivery of the baby and the delivery of the placenta, this is the time where perineal lacerations or episiotomy are best visualized and repaired. And the placenta separates, it's usually delivered 2 and 10 minutes after the baby, and then a uterotonic agent can be used to help the uterus contract during this phase. And then the fourth phase of delivery typically lasts about 6 hours, and it's considered over once the patient has been stabilized. Okay, so here I've broken down the different periods where physical therapy intervention is indicated. The bolded areas, so or what should be 2 through 4 here, are periods where PT services are underutilized, in my opinion, and based off of my reading. And so as far as I know, they're not performed here at GSPP. So we'll go through each phase of the pregnancy continuum and review the literature associated with each. All right, so we'll start with outpatient prenatal care, which can occur anytime during pregnancy, and then outpatient antepartum labor and delivery training, which is recommended to begin at 36 weeks gestation or later. Okay, so interventions during outpatient prenatal care. Perineal massage is one of the most well-studied prenatal interventions that's been shown to decrease the rate of episiotomy use, perineal tearing, and the length of the second stage of labor. I've included several systematic reviews in the reference section to support this, but optimal results were demonstrated when patients performed this massage 1 to 2 times weekly for 5 to 10 minutes, and the start studies varied between beginning at 32 weeks gestation to 37 weeks gestation. And then there is an abundance of labor preparation on the internet, but it's important for healthcare professionals, including physical therapists, to be reviewing this process with our patients. So providing information regarding the stages of labor, different labor positions, which we'll touch a little bit more on later, and then the controversial evidence on breathing techniques should be provided. And in regards to labor preparation, biofeedback can also be a very useful tool to facilitate downtraining of the pelvic floor and to reduce the risk of a paradoxical pelvic floor muscle contraction during pushing. And I was actually surprised to find that this was a very understudied area, but it might be a low-risk adjunct to any other evidence-based prenatal interventions you're using. And in my own anecdotal experience, my patients tend to report less anxiety about delivery and more confidence about breathing techniques and pushing techniques, and just finding positions that work really well for them and help facilitate a relaxed pelvic floor. And it's been previously proposed that pelvic floor muscle exercises during pregnancy reduce the risk of postpartum stress urinary incontinence and fecal incontinence. However, most of the recent literature demonstrates no significant outcomes over control groups who don't perform the pelvic floor muscle strengthening during pregnancy. But increased pelvic floor strength and endurance are not correlated with instrument deliveries or vaginal tears, but a high mid-pregnancy pelvic floor resting pressure is associated with a prolonged second stage of labor. So this is where prenatal biofeedback can be helpful to practice the downtraining of the pelvic floor during delivery. And then additionally, addressing any other musculoskeletal impairments, particularly pelvic girdle pain and low back pain, as well as encouraging exercise are important things to incorporate. So I could give a whole separate presentation about pain and exercise in pregnancy, but it's a little bit beyond the scope of this presentation. I did include some updated resources in the reference section, and I wanted to note that the American College of Obstetrics and Gynecology updated their exercise guidelines this year. And so while we typically see patients who are referred to us for pelvic girdle pain and dysfunction, these interventions really should be provided to all pregnant in order to optimize their outcomes. All right, so another topic that I wanted to bring up was the recent and pretty promising evidence about elective labor induction at 39 weeks gestation. So a 2013 retrospective study assessed the outcomes of elective labor induction in over 300,000 patients at 37, 38, and 39 weeks gestation. So they found a significantly reduced incidence of cesarean delivery among both nulliparous and multiparous women who had had a previous vaginal delivery. Likewise, there was no increased risk for neonatal ICU admission, respiratory distress, or perinatal death. Another 2019 meta-analysis of 6 cohort studies, including almost 600,000 participants by Grobman et al., demonstrated that elective labor induction at 39 weeks gestation was associated with lower risks of cesarean delivery, maternal infection, adverse outcomes, ICU admission, and mortality. So I thought this was pretty interesting, and I included several other systematic reviews and meta-analyses in the reference section. And then I also wanted to mention that we actually have a randomized control trial going on here at Penn that's geared towards implementing a planned labor induction policy at 39 weeks. One of my patients told me about it, and it sort of spurred this little lit review. And of course, this isn't something that we as physical therapists have control over, but it's something that we could recommend that our patients discuss with their OBGYN. Okay, so moving on to inpatient intrapartum support. So physical therapy interventions actually performed during labor and delivery. Okay. So here we'll cover the biomechanics of delivery. This is the most common fetal presentation, but it's important to note that a variety of deviations from this can occur. During engagement, the head moves so that the widest part of the fetal head fits into the widest part of the pelvic inlet. The baby then descends through the pelvic inlet towards the pelvic floor. This occurs by uterine contractions and also active contractions of the maternal abdominal muscles. As the fetus descends, the head comes into contact with the pelvic floor, which causes neck flexion. It makes the fetal diameter smaller so that it's easier to pass through the pelvis. This forward and downward slope of the pelvic floor allows the fetus to rotate and lie underneath the suprapubic arch, which will eventually result in crowning when the widest part of the fetal head makes it through the narrowest part of the bony pelvis. The occiput then slips beneath the suprapubic arch, causing extension of the fetal neck As this occurs, the fetus pushes against the perineum, which causes it to stretch. And then finally, the head externally rotates to face the medial thigh of the mother. The shoulders can realign 90 degrees, and the position is termed restitution, so the baby can be positioned and delivered. Okay. So here are the biomechanical goals of delivery. This was taken from the Academy of Pelvic Health's OB1 course. And a study by Zimmerman, published in the Ultrasound and Obstetrics and Gynecology in 2018, assessed hip flexion angle with the angle of progression during second stage of labor. Based off of the results of the study, they recommended a McRoberts maneuver, or hip flexion greater than 120 degrees, to increase the chance of a spontaneous vaginal delivery. However, the only position they recommended to achieve this was a supine dorsal lithotomy position, where the patient is just lying on their back with their hips flexed and knees flexed as well. So I found an interesting study by Dessuave et al. In 2019, where they were looking at the associations between the pelvis orientation, lumbar curve, thigh postures, specifically hip flexion and abduction of the mothers throughout the pregnancy. And this is one of the first studies that also adjusted for joint laxity using a modified Jobin's extensometer. And then while the optimal birth conditions were never really reached by this study, they laid the groundwork for future research in the field of obstetrical biomechanics. All right, so breaking this down a little bit more, during the later stages of delivery, as the pelvic outlet opens, the maternal pelvis is required to move in a variety of different planes. So it's important for lumbosacral and pelvic mobility to be free in as many possible planes. So the dorsal lithotomy position might not be the most optimal position to give birth in. All right. So what can we as PTs do during labor? According to the updated 2019 guidelines by the American College of Obstetrics and Gynecology, evidence suggests that continuous one-to-one emotional support during labor is associated with improved outcomes such as shortened labor, decreased need for analgesia, fewer operative deliveries, and fewer reports of dissatisfaction with the experience of labor. This support is often provided by a nurse or midwife, but I don't think it should necessarily exclude physical therapists, especially if we have been seeing them throughout their pregnancy. The guidelines also recommend frequent position changes during labor to enhance maternal comfort and promote optimal fetal positioning, as long as they don't interfere with appropriate maternal and fetal monitoring. And we'll be going into different labor positions next. But in terms of breathing, there is substantial but conflicting evidence about whether to allow women to breathe spontaneously or to coach them in the Valsalva maneuver. In 2018, Garpiel described that Valsalva-directed pushing is taking a deep breath in, holding, tightening the rectus abdominis muscles, and bearing down for a count of 10. However, the 2019 ACOG guidelines stated that when women weren't coached to breathe in a specific way, they actually naturally push with an open glottis. And so in consideration of the limited data regarding the superiority of spontaneous versus Valsalva-directed pushing, each woman should be encouraged to use her preferred and most effective technique. So it would be really beneficial to have already assessed and practiced different breathing techniques and their effects on the pelvic floor with or without biofeedback. And there was previously some controversy between delaying pushing in order to preserve maternal energy and initiating pushing at the very beginning of the second stage of labor. But in light of some recent study findings, the data generally supports pushing at the start of the second stage of labor for women who are receiving epidurals. So delayed pushing has not been shown to significantly increase the likelihood of a vaginal birth, and the risks of delayed pushing, including infection, hemorrhage, neonatal acidemia, should be shared with our patients. There were 2 meta-analyses of randomized controlled trials comparing maternal and neonatal outcomes in women assigned to immediate versus delayed pushing. Both of the studies found that delaying pushing for 1 to 2 hours actually extended the duration of the second stage by approximately an hour. And although both reports it noted an increase in vaginal delivery rate, this difference was no longer significant when the analysis was restricted to high quality randomized controlled trials only. And then another recent large retrospective analysis found that delaying pushing by 60 minutes or more was not associated with increases in cesarean delivery, vaginal weight, postpartum hemorrhage, or transfusion. All right, and then perineal massage. A 2017 systematic review of over 15,000 deliveries assessed the outcomes of both perineal massage and use of warm compresses on the perineum during the second stage of labor. They found that perineal massage was associated with intact perineums and fewer third and fourth degree tears. There was no association between massage and the first and second degree tearing, though this was considered moderate quality evidence. Fewer women in the warm compress group experienced third or fourth degree tears, but the compress did not affect the number of women with intact perineums, first or second degree tears, which was low to moderate quality evidence. And then a pilot study published in 2017 in the Ultrasound in Obstetrics and Gynecology Journal looked at the use of a transperineal ultrasound as a method of biofeedback during the second stage of labor. They found that pushing efficacy increased significantly following visual biofeedback. The association was found between biofeedback and an intact perineum following delivery. There were no significant differences with regard to mode of delivery or length of the second stage, but feelings of maternal connectedness with the newborn were significantly stronger in this group. And the American Academy of Pediatrics in 2014 found that water immersion during the first phase of labor was associated with shorter labor, decreased pain, and decreased use of epidural anesthesia. A 2018 meta-analysis of 34 studies revealed no association between water birth and poor neonatal outcomes. So this is generally considered a safe and low-cost method of pain management for women in labor, but should not interfere or prevent other elements of care, including appropriate fetal and maternal monitoring. So here I've compiled a list of delivery positions, whether or not used with an epidural, and some potential benefits for each position. Some of these positions, specifically the upright positions, might be more helpful during the first phase of labor to just utilize gravity for delivery, while several others will be more helpful during the active pushing phase. I included this chart with some other handouts for you guys to reference as needed. And in my own experience, my patients report feeling more confident about the delivery process after we run through some of these positions with biofeedback and breathing techniques. So it's helpful for them to know that there are other options besides laying on their back, and it gives them a little bit more autonomy with their birth. Okay. And then at the combined sections meeting in 2020, I listened to a group of pelvic physical therapists from Colorado describe their PT interventions across the continuum of care. They had created this template to provide information gathered from their assessments and could make recommendations about labor and delivery options to the physicians and nurses. They worked in a hospital-based outpatient system, which was very similar to GSPP, and they had substantial evidence supporting their interventions, as well as excellent physician relationships and buy-in. So I thought that this was a really fantastic way to not only bridge the gap between outpatient and inpatient prenatal care, but a great marketing strategy for these services that we offer. All right, so inpatient postpartum assessment. So physical therapy interventions within 72 hours of delivery, ideally before the patient leaves the hospital. So we typically see our patients after their 6-week follow-up appointment with their physician, and it's usually only if the physician identifies a significant impairment. But there are so many things that we can assess and educate on immediately after delivery before the patient leaves. And often a lot of complications can be avoided with early identification and intervention. So firstly, we can figure out how the patient is doing mentally and emotionally. We'll touch a little bit more on postpartum depression in a minute, but we should look at their demographic information and access to healthcare, as well as their support system, in order to identify any additional assistance that they may need. We can take a look at their integumentary system and how their wounds may be healing. And we can, of course, assess posture, breathing, abdominal and pelvic floor activation, as well as a gait assessment to identify any potential skeletal or neurologic injuries that could have occurred during birth. And then it's extremely important, if we have not already done so, that we educate these patients on appropriate mechanics for lifting, carrying, and breastfeeding their infants. And if they're having trouble with something, we should make sure that we get them the supportive equipment that they need as soon as possible. Okay, so postpartum depression is a specific mental disorder for which preventative interventions could have dramatic benefits. And depression is one of the most common complications of childbearing. A meta-analytic review found that approximately 13% of all women will experience a major depressive episode during their first postpartum year. The most common measure to screen for depression related to childbearing is the Edinburgh Postnatal Depression Scale. This is a self-report instrument that contains 10 items ranked 0 to 3 that reflects the patient's experience over the past week. It's been validated extensively for use in both the postpartum period and during pregnancy. A 2013 systematic review of 28 randomized controlled trials, including almost 17,000 patients, found that women who received a psychosocial or psychological intervention were significantly less likely to develop postpartum depression compared with those receiving standard care. And in terms of other interventions, aerobic exercise has been studied extensively for preventing depression in this population. A 2017 systematic review of over 1,700 participants by Pritchett et al. Found that aerobic exercise improved depression symptoms in both at-risk and low-risk participants. Another 2019 systematic review by Carter et al. Found potential benefit of exercise interventions, though the guidelines were poorly established and lacking statistical significance. So while establishing guidelines for exercise as a treatment measure for postpartum depression still requires additional research, cognitive behavioral therapy has been established as an effective treatment and prevention option. A 2015 systematic review of the efficacy of cognitive behavioral therapy for treating and preventing perinatal depression found statistically significant improvements, though the stated benefits were greater during the postpartum period compared with prenatal interventions. And recommendations based off of this research are to administer appropriate outcome measures, provide education on exercise, and refer to a cognitive behavioral therapist as needed. Okay, so this is an area that we address pretty dang well here at Good Shepherd Penn Partners, and the evidence supporting the interventions that we use here has been around for quite a long time. So we'll go into outpatient postpartum care and then fourth trimester support. So a 2010 systematic review of the prevalence of urinary incontinence found that during the first 3 months postpartum, the prevalence of any postpartum incontinence was 33% in all women. Likewise, a reported prevalence of postpartum anal incontinence was varied between 4 and 39% at 6 weeks postpartum. Pelvic floor muscle training has been shown to improve symptoms of urinary and anal incontinence. Treatment has 3 progressive components. So the first step is getting our patients to perform a successful voluntary contraction and relaxation of the pelvic floor. Once a patient can successfully perform this, specific pelvic floor muscle exercises can begin. And then the final step involves neuromuscular re-education, where the pelvic floor muscle training can focus on timing a pelvic floor muscle contraction with a secondary event that usually leads to incontinence for that patient. For example, performing a contraction before standing up or accelerating during running. This is referred to as the knack. And then sportswear and clothing aimed at supporting the pelvic floor is gaining increased awareness and understanding for the benefits that they may offer. Okayama et al. Demonstrated in 2019 that wearing supportive underwear was almost as effective as pelvic floor muscle training in reducing stress urinary incontinence in women at the end of a 6-week trial. And of course, we don't want our patients relying on external support. Thank you. but they may be a good supplement for select patients. And then pelvic girdle pain. So the incidence of pelvic girdle pain and low back pain during pregnancy is actually quite high, with the prevalence in late pregnancy reported to be greater than 50%. So unfortunately, about 37% of women will have low back pain that persists more than 3 months postpartum. Treatment of postpartum patients with either of these dysfunctions was assessed in a randomized controlled trial by Stooge et al. During the 20-week program, 40 patients performed specific lumbar stabilizing exercises, while the other 40 patients performed non-specific strengthening exercises. The authors reported that the program containing specific stabilizing exercises for the lumbar spine was considerably more effective in reducing pain, improving functional status, and improving health-related quality of life compared to the non-specific strengthening exercises. So diastasis rectus abdominis is defined as an impairment caused by the midline separation of the two rectus abdominal muscles along the linea alba. The prevalence rate of diastasis rectus abdominis, or DRA, is around 33% at 12 months postpartum. The research surrounding the assessment and interventions for this is actually kind of all over the place, but ultrasounds have been used as a way to measure the distance between the two rectus abdominal muscles at several points along the abdomen. Other imaging can be done to assess the actual thickness of the abdominal muscle tissue, and then a visual assessment of abdominal doming during activity can be used. But several of the common interventions to improve rectus diastasis have conflicting evidence. For instance, there is insufficient evidence for whether or not a maximal draw-in contraction of the abdominal muscles decreases or increases the interrecti distance. A recent 2020 cross-sectional study found that performing a pelvic floor muscle contraction with an abdominal draw-in temporarily increased the interrecti distance according to a two-dimensional real-time ultrasound, while several small studies demonstrated improvement in abdominal wall thickness and ability to return to exercise following abdominal strengthening protocols. So I think it's important to consider the quality and thickness. Thank you. To consider the quality and thickness of the underlying musculature, as well as the patient's ability to maintain control of their abdomen during functional movements, instead of relying on a linear measurement for progress. And then sexual dysfunction. Women often experience pain during or after intercourse, reduced desire, arousal, and orgasm in the postpartum period. Physical therapy interventions include perineal scar massage, dilator therapy, lubricants, positional strategies, and then again, referring to a cognitive behavioral therapist if the suspected cause is psychological. And then back to the dilators, I wanted to mention a few poster presentations I presented at CSM in 2017 on the use of graded exposure and proprioceptive neuromuscular facilitation techniques for a woman with vaginismus. The contract relax techniques can be used with or without dilators and have been shown to be effective treatments for vaginismus. And then circling back to rectus diastasis, because it's a very common thing that we see, and it's something that our patients read a lot about on the internet. And while I was looking into the literature on this, I really couldn't find any systematic reviews or even randomized controlled trials that supported significant results of any particular intervention. But I did find this consensus study that was done among 21 women's health physical therapists in 2019. They participated in a 3-phase Delphi consensus study to try and sort out appropriate intervention recommendations for patients with rectus diastasis, both during pregnancy and in the postpartum period. So this chart represents phase 1 and 2 items that had greater than 80% consensus among the experts. So this might serve as a good reference for you guys when selecting interventions for this patient population. Most of it involved not performing any concentric contraction of the abdomen, not performing any exercise that caused doming of the abdomen, making sure the patients could maintain continence with all of their exercises, and then coordination of the pelvic floor with abdominal contraction. Okay. In 2015, the American College of Obstetrics and Gynecologists recommended that patients gradually resume physical activity after pregnancy as soon as medically safe and dependent on the mode of delivery. However, determining readiness to resume exercise, specifically high impact activities, has been proven to be a very difficult task. In 2019, a literature review by Goom et al. Is the most comprehensive review that I could find on this topic. Most of their recommendations are based off of expert opinion, aside from the evidence that postnatal women can benefit from an individualized assessment and guided pelvic floor rehabilitation after delivery. So really the only thing that they found statistically significant was the fact that people needed to go see a PT. And one thing that I did find that was consistent among many recent studies was the recommendation to not resume high impact activity for at least 3 months after delivery. So the assessment of pelvic health, load impact management, and strength testing from this study was based on expert clinical consensus, drawing from the best available evidence. No studies specific to the postnatal population have been carried out to evaluate the readiness for a return to exercise, but they did suggest this activity assessment for returning to high impact activities. So it includes walking for 30 minutes, standing on one leg for 10 seconds, 10 single leg squats, jogging and on spot, forward bounds, hopping in place, and then single leg running man. And then the patient needs to be able to perform all of these activities without pain, heaviness, dragging, or incontinence before they should resume high impact activities. Okay. So if our patients shouldn't immediately return to running, what can they do in the meantime? So the same 2019 GOOM study prepared this gradual generalized return to exercise guidelines based off of the literature review that they performed. Of course, each patient is different and requires a specialized assessment by a physical therapist to address their unique needs, but this could serve as a framework to build a treatment plan off of. Okay. And then, of course, referring patients to the awesome courses we have here at GSPP. These classes provide evidence-based approaches to exercise and interventions during pregnancy and afterwards, and they are all virtual. And then based off of this literature review, I created this checklist for physical therapy interventions across the continuum of pregnancy and the postpartum period. I had the lovely Lisa Tate take a look at it for modifications, and so the final draft will be available to you guys whenever we send out handouts. So I included a checklist of things for prenatal interventions, things that can be done during delivery, things that should be done within 72 hours of delivery, and then what to do at their 6-week checkup. So if a patient has a high-risk pregnancy or is just planning a cesarean delivery, it's a good idea to encourage them to complete some prehabilitative exercises and provide them with education about what to expect in terms of pain, numbness, general mobility, and then functional limitations that they'll have afterwards. Diaphragmatic breathing can begin day 1 post-op to help with bowel motility, lymphatic flow, and restoring the length and strength of the abdominal muscles. And also a light walking program can typically begin day 1 after delivery to help with bowel function as well. So the patient should receive education to improve their functional mobility with transfers, infant management, coughing and sneezing, such as using a pillow to brace the abdomen, as well as postural re-education. Clothing recommendations can include stretchy waistbands, placing a pad between the surgical wound and clothing, as well as specialized cesarean birth underwear with a silicone panel. Then scar management is a really important and often overlooked component of cesarean rehab. So our patients should be educated about the phases of wound healing, scar massage, and how to monitor for signs of infection. And I listened to a talk by one of our therapists, Erin Fazari, about wound healing, and she told us about an interesting use of masking tape to help facilitate scar remodeling. A randomized controlled trial of 70 patients who had cesarean deliveries found that applying paper tape along the length of the scars once the sutures were removed significantly reduced scar volume and their chance of developing a hypertrophic scar. So in this study, no one in the treatment group developed a hypertrophic scar compared with 41% of the control group. So the tape was applied for 12 weeks and assessed at 6 weeks, 12 weeks, and then 6 months postpartum. And you really can just use paper tape. I tend to use kinesio tape because it lasts a little longer and it looks a little bit more legit, but masking tape is a perfectly fine, affordable option. Okay. So for the sake of time, I'm not going to go into detail about these topics, but I did want to include some resources that I thought were very helpful for some of the common dysfunctional labor populations that we see. There's been some substantial evidence released about vaginal births after cesarean deliveries, fetal presentation complications, and instrument use during vaginal delivery. And then the picture I included is for a new vaginal delivery assistive device called the Odin device. In 2017, a pilot study was completed, including 49 patients for this device. Of the 49 women enrolled, the Odin device was inserted successfully in 93%, and then successful Odin device delivery was achieved in 71% of women. First and second degree perinatal tears did occur in 59% of the women, but there were no third or fourth degree perinatal tears observed. So this is just something to look out for in terms of future research. I haven't seen any other studies on this aside from the pilot study. And then I also wanted to include some resources for specific pregnancy and delivery populations. These are the sum of the age, musculoskeletal, neurologic, and cardiovascular disorders that we could see pre or postpartum. So I've added the references for your leisure. A group of inherited, next slide. And then I wanted to open up the discussion about ways that we could improve our pregnancy and postpartum program here at GSPP, and whether or not we think it's feasible to offer inpatient, acute, and postpartum interventions. So found this pretty generic article on marketing considerations, and I wanted to see how some of these things could be applied to our practice. And we already have a very well-developed pregnancy and postpartum program with work groups and classes and handouts, so we have a pretty good foundation to work from. Some of the goals to consider could be increasing the number of patients who get a prenatal PT consult, increasing our presence during active labor and delivery, ensuring that every patient has a PT before leaving the hospital, or at least within 72 hours of delivery. And then at a bare minimum, making sure that every patient gets seen after their 6-week physician follow-up, whether or not they had any overt complications during labor. And then some of the ways we could measure this would be through tracking perinatal tearing and dysfunctional labor statistics, patient satisfaction outcome measures, and then just continuing to build our physician referral network. And then the rest of these are just considerations for how to make this possible. As far as I've seen, PTs in Philadelphia are not typically in the labor and delivery rooms, especially during these times, though some private practices and midwife services do complete these prenatal and intrapartum consults. Okay, and then some of my references for you guys to refer back to if you'd like. And wanted to say thank you so much to all of these wonderful people who helped me through this pretty insane year. Definitely couldn't have done it without you, and I appreciate your support and clinical expertise. And then I wanted to open up the floor for any questions. A lot of talking. Yes, Denise.
Yes. So, I have a question. So tape.
Yeah.
Any tape, you're saying, any.
They use masking tape.
Any
Paper tape is actually 3M paper tape, not specifically the masking tape we use to do.
Oh, so the paper tape, the white paper tape.
3M paper tape.
Okay, 3M paper tape.
Is usually, I've been doing that article on all my C-section patients, but like.
Yeah, I have to.
Before C-section. The nice thing about it is you can use it, like the wound doesn't have to be completely healed.
Yeah, that's good.
I'm sorry. Yeah, the nice thing about it is the wound doesn't have to be completely healed either. In fact, I think in this study, and maybe you know, because you write so frequently, her works, but it said that it was recommending after sutures
Yeah.
and staples were removed, that you can start using paper tape.
Yeah. So the question was, can you really use paper tape for this? The answer is yes, and you can use it after the sutures were removed, but the wound doesn't have to be completely healed.
My second question is in regards to the DRA, since we kind of get those all over, we get a lot of referrals for those, I think, which is kind of a thumbs up, but still a question mark, I think, in my opinion. I was wondering if you came across any, and I'll go through your references, but Hodges and Lee did an article on what they are terming as a term called the distortion index.
Okay.
Are you familiar with that?
I did not come across that article, but yeah, I'd definitely be interested in looking into
The interesting part
it.
is this index is what it's showing is that during a curl up, actually something that many of us maybe tell patients not to do, actually draw the borders of the left and right rectus together.
Interesting.
But a transverse abdominal exercise actually keeps that split apart. And so there's this distortion index that is building tension, and that's that when you're kind of touching the space in between, that's kind of what you're feeling. Is there any pressure? Is there any tension that's building in between there? And that's the distortion index. I was just wondering, in terms, and I actually recently, probably just as much as 3 months ago, just was on a pod group talking this, and we're all talking about different things. Yeah, so there's still no consensus, is I guess what my point is, is what we're talking about on how to rehab. I just haven't seen any follow-up to that article of that distortion index, because in certain ways we're training, if a person's goal is to bring the two sides together, we're actually not looking at bringing this, that's not the first goal, it's really building.
And I'll usually tell my patients that, they're just, I want my muscles to come back together, I want to look like I did before, but they may not see the actual change in distance between the two rectus abdominis muscles, but if they can at least improve the quality of tissue and the ability for them to control the abdomen, or at least that doming that you see, which is pretty prominent. If someone goes to do an activity and they don't have good control of their abdomen, they'll see a pouch. And I typically have them avoid any activity that causes that. But I don't usually say, okay, yeah, let's measure the distance and we'll hope that it comes back together, because that doesn't always happen and doesn't actually really lead to improved function.
And my last, because I don't want to monopolize, so we'll look for more research on that to see if there is any more follow on that distortion index. But the other, I love your ideas about, hey, how can we get there in acute care? And I think, some of us have been talking about that for a long time, like how, because this is missed. This is an opportunity it's an opportunity. So I love that you're coming up with these great ideas and going to be with us for a year working on those with those that are interested in
after
and
vacation.
wondering if real quick, like almost right out of the gate, would be interesting is if we, as you mentioned, we have a pretty strong program that everybody who's delivering at Penn, that their information includes us in there right at the get-go, because I don't know. I can remember from me being in the hospital, I wanted to get in and get out, and I really didn't even want to stay. I was like, listen, you need to let me go. I didn't want to see anybody or anything. So, having at least, but I did go through my little, folder when I got home, And so I thought if we could at least quickly get in there, that would be a start for opening the doors.
Even if it's telehealth, I mean, it's so
because
easy
if
now
you
that we
switch
have
on
these
the last
options.
trimester information that ACOG has come out, if they have a practice bulletin with it, less than 50% are still getting to their 6-week follow-up.
Wow.
So we have to be even before that.
Yeah.
Good, nice work.
Yes.
So, wonderful presentation, I learned a lot.
Thank you.
I actually work in the acute care side, I work at Pennsylvania Hospital.
Oh, cool. So do
And
I.
I've seen a few women, well, what I want to say is get in there. I really, this would be really great for the patients. The patients that we've gotten consulted on are patients who have either, their epidural takes a long time to wear off and are very difficult with walking, or they have some like foot drop afterwards that could be related to the epidural, not related to the actual birth and their pelvic floor, but we'll go in there and then they have all these questions about, Kegels, that's what they want, and also like how to carry the child. So I think that's a great initiative to do. Even getting in postpartum and doing like some sort of education like you're talking about, the women that are there, I don't know, that I've treated, would really benefit from that.
Cool. Yeah, definitely interested in getting that going.
And then I have a second question.
Sure.
So does the epidural, when you say it affects delivery, is delivery typically faster or shorter? Because
It's longer.
longer.
Yeah, if they have epidural. They don't know exactly why, but it could be that they're just not as in tune with their body. They're maybe not able to push as effectively or get into positions that facilitate an opening or lengthening of the pelvic floor. So it increased the delivery time. Sam?
I have a question about the chart that you had with like, the positioning.
Yeah.
Was that so, at least when I was going through it, they all said like, you can do whatever you want during labor, but for delivery, you have to be in the normal, position. So is that chart for laboring? And like when let's say we were seeing someone pregnant, are we looking at them, if you're doing biofeedback or something, are we doing this for the laboring position and working on it? Or is this specific for delivering?
I think it depends on the place that you're delivering in and the comfort of whoever is delivering your child, whether or not you're high risk, whether or not the doctor feels comfortable delivering, if they can visualize everything, if they can accurately monitor. But a lot of these positions are for the labor process, but then delivery, depending on the physician, or if it's not a physician delivering your baby, potentially could. I think that'd be a good question to have our patients recommend they ask their doctor, is if they're comfortable delivering in a different position. And I think creating a template for just like, hey, I did this assessment on this patient. Her pelvic floor was most relaxed in these positions. These are some of the orthopedic things that she already has going on, maybe to look out for. Bridging that gap and touching base with the physician, I think would be really helpful to hopefully at least educate them that they can give birth in more than one position. And then, hopefully they get on board with that in future deliveries too. Cool.
I think there was, Shannon had a question. I don't know if she can connect or not.
Let's see. I wouldn't know how to make.
You have to Shannon can unmute herself if she has a question.
Okay, cool. Sure. Shannon?
Can you hear me?
I can hear you.
Hi, Julie. Great
Hello.
presentation. Congratulations on
Thank
everything
you.
you've done. This is just kind of a broader question. I'm curious what you've come across in all this reading that you've done. You made a reference to the fact that we, especially in the United States, could do more here. So I was just wondering if you had read any protocols, that are in place right now internationally, especially, I guess, in some of those socialized medicine countries that struck your fancy, so to say, or like what are other physios doing in this area, or governments, I guess, for that matter?
Yeah, that's a really good question. And I did not look into any specific protocols that other countries have, but I do know that in France, most hospitals It's customary that every woman gets at least a follow-up with a physical therapist after delivery. I don't know if that has to do with like the social structure or the socialized healthcare aspect, but a lot of other developed countries have been implementing PT into just like their standard of care for decades. So I feel like the United States is a little bit behind in that, but I can definitely look into some protocols because I'd be interested to see how other countries standardize that. That's a good question.
Yeah, thanks.
Mm-hmm.
I think Emily has a question. Emily.
Okay.
Julie,
Hello.
hey, wonderful job. That was excellent. I just wanted to kind of comment because I think that your ideas about implementing a little bit more PT presence in the delivery room and even after delivery is so important. When I was over at HUP, so Hospital University of Pennsylvania, I had the opportunity to see patients on the labor and delivery floor afterwards, but it was like very brief and we were consulted maybe on a monthly basis. And after I had gotten some experience with pelvic PT, I had brought that education to those patients up there. And I just feel like just referring them to outpatient, they were so thankful. And it's interesting, when I first started out and I got consulted up there, it was just so foreign to me as a PT. And I feel like even just educating staff in different acute care settings can be super helpful. So yeah, great ideas. And I love that. So I just wanted to comment.
Cool, thanks. Yeah, that's awesome. Yeah. I did a clinical rotation when I was a student and in acute care, and they knew I had an interest in pelvic health, but I really didn't know anything at the time. So every now and then they would send me to see a woman, after delivery, maybe cesarean delivery that was having a difficult time getting around. But yeah, they were very infrequent. Like maybe I saw one or two in the 10 weeks I was there. So
definitely, great job.
Okay, and we are out of time, but my email is the typical Penn email, julie.jenner@pennmedicine.upenn.edu. If you guys have any more questions or want any more information. Thank you.
Great job. Okay, so now we're going to move on, and Becca if you have other questions, just send your questions in, not through the comments. I just realized that they keep coming up, but through either just probably direct them directly to Julie through her email, like she said. Okay, so. Oh, yeah. How do I do that? You're going to get pick there. And then stop.